You know, sometimes when I start my show, I try to come up with some humor, some comedy or something funny, but I'm not going to do that this time because what we are discussing today is not funny. It is not anything to be played with. And what we're going to talk about in today's segment, courtesy of Madison Health and Megan Allen, is that we're going to talk about with some doctors some of the issues in our community that one way or another affects all of us. And of course, it's our goal and our mission to impart significant and useful information that will, of course, help to make life better for all of us and help to address some of the problems or illnesses and bad habits, etc., that we have in the community. So today we're going to talk about first with Dr. Clark about summer safety, and then our second segment is going to begin, and like I said, it's not funny, but we're going to talk about drugs and its effect on our society, addiction and use and treatment and things of that nature in an effort to educate the community and, of course, help to address that problem. This is a call to action.
A call to action.
I'm your host, Alex Havisham, and I'm glad to have in our second segment no one but someone in the person of Dr. Paul Seale, who is an expert, MD, of course, but he deals basically with drugs and addiction and things of that nature. And because of all of the recent publicity about opioids and the tragedy, matter of fact, Doc, I heard this morning on CNN that, that is in some communities, and I think it was in Ohio, deaths from opioids were just skyrocketing. And, it's kind of sad. Matter of fact, the morgue had about 40 bodies in it for people who had just overdosed on drugs. So what we want to do is try to use this session as an informative session to try to talk about, what some of the signs are of drug addiction and some of the ways you can detect people who are on drugs and how to avoid them and what the treatments are and things of that nature. So welcome to the show.
Thank you very much. Pleasure to be with you.
I hate to take all your time with my introduction, but we'll get the information. Okay, tell us a little bit about yourself.
I'm a family physician. I work at the Family Health Center out on Eisenhower Parkway. I actually was a resident here at the medical center back in the early 1980s, and I've been back in Macon since 1997, practicing family medicine, teaching at the family medicine residency program, and most recently trying to help start a fellowship in addiction medicine to try to train more leaders to treat the problems related to alcohol and drugs that are so prevalent in our communities.
Thank you, sir. So basically, what does your job entail?
Well, I have a great and fascinating job. It involves taking care of patients. So typically on Mondays and Thursdays, I'm in the office a good part of the day seeing patients, and several times a year rotate on the hospital service. We take care of people who are more ill, have to be hospitalized. I'm also research director for the Department of Family Medicine, and we do research. A lot of our research, most of our research right now is related to alcohol and drugs. And then we teach and train medical students and residents, so we're always busy trying to teach and train the next generation of family physicians that are so much in need in this country.
Yeah, and to put it short, you're a busy man. Let's move specifically toward drugs. What kind of problem? Do we have a real problem based on your experience in Central Georgia? Well, let's separate them. Let's talk first about alcoholism.
Sure.
What kind of drives or leads to alcoholism?
That's a great question, and I got really interested in this field because I have a lot of alcohol problems in my family, and growing up, I witnessed my family members going to doctor's offices a lot, going in and out of hospitals. And what I saw for the most part, 90+% of the time, was that either their alcohol problem was not detected or diagnosed, or if people were aware of it, they really didn't treat the underlying disease. They treated the consequences. They patched people up and they sent them out again, and then they continued to drink heavily, and oftentimes reach a premature end due to the problems related to alcohol. We know now that about half of the risk of what we've called alcoholism or alcohol abuse, now the newest term is alcohol use disorder, about half of that risk is genetically determined.
So, right there. So that is true.
So that is
some
absolutely
people,
true.
a lot of people have said that, but I hadn't heard that it was a research phenomenon, a documented phenomenon. So talk a little bit about that.
Right. So, I have relatives in my parents' generation, my grandparents' generation, who had problems with alcohol or drugs. And so I know that I'm at higher risk. I know that my children are at higher risk to have problems related to alcohol. One of the puzzling things about alcohol use disorders is that those of us who grow up in families where there are alcohol problems oftentimes marry into families that have got similar problems. They think what's happening is the kind of relationships that happen in those sometimes called dysfunctional families feel normal to us, and so we find other people who are coming out of the same kind of background. And so oftentimes our spouses then have family members with alcohol problems, and we have children and cousins. And
now, do they get the double whammy? I mean, if a person with the genetic disorder marries a person with the genetic disorder, then are they twice as likely?
The risk increases even more. It really does.
Wow. Now, what are some of the ways to try to avoid it? So what you're saying, if in fact a person has the genetic disorder, then, how should one address that from a family perspective?
Right.
For example, if my granddaddy was an alcoholic, and though I may not be one, I need to know that I might be susceptible to becoming one, but I need my children to know that that may be passing along. Right. So how do you address and approach that?
Yeah, so I think you touched on the first point, and that is that if a person knows they have that genetic makeup, it's their responsibility to teach their kids and their grandchildren that they're at risk, that alcohol is probably not as safe for them as it is for other people in the population. So that's the first thing is teaching that risk is elevated. And then the second thing, obviously, if you don't ever drink alcohol, you won't ever develop an alcohol use disorder. So that's the safest thing. And it's surprising that roughly half of American adults do not drink. And I share that statistic, and from time to time, I know one of my daughters, when she was in college at Emory, she said, "That's not true."
Everybody at Emory drinks, huh?
And what she was reflecting was the fact that in the college population, the drinking rates are higher, and heavy drinking rates are also higher.
Wow.
So we all tend to think, however people around me drink, that's what the world is like. But it's not that way. And so it's really not as strange as we might think to say, well, a safe thing and a wise thing to do if you know that risk is not to drink at all. Now, there is another pathway that's being taught now, and I think time will tell how effective it is, but the National Institute on Alcohol Abuse and Alcoholism has promoted what they call a lower risk drinking guidelines. And in a nutshell, most of us, if we don't ever get drunk, we're probably not going to get into problems with alcohol. But what they've defined, they got scientists together and said to the scientists, tell us based on your research, what would a safer level of drinking look like? And what they determined is, first of all, it's different for men and women. Women's bodies are much more sensitive to alcohol than men, so women should not try to match men drink for drink. That's a very dangerous thing to do. Men are recommended to drink no more than 14 standard drinks, Standard drink would be a 12-ounce can of beer or a 4 or 5 ounce
A day?
glass of wine.
A day?
No more than 14 in a week.
Oh, we go.
And if
That's
it starts,
2 a day, pretty much.
right,
2 a
and-
day.
or if you're saving them up, as some people like to do, because we got a lot of weekend drinkers in the United States. No more than 4 in a day for men, and no more than 3 in a day for women. And a woman's weekly limit should be 7.
Okay. So if in fact you are prone to being an alcoholic, and if one has the discipline to follow that 14 in a week rule for a man, or 7 for a woman, then it's less likely. Now, are you suggesting or indicating that if a person has that genetic possibility, then if that person tends to drink more, then they are more. He or she is more likely to become addicted.
Right, and that's a very, very important thing for people to understand. And I spend a lot of time working with people with alcohol problems. I spend time in recovery circles, 12-step meetings. And what people will tell you who have this disorder is alcohol does not affect them the same way. So if, for example, you didn't have that problem and you had 2 drinks, it's probably not a big thing for you to take it or leave it. If you have that different metabolism, that different brain response to alcohol than many people with alcohol use disorders have, then you may likely get a better buzz, a higher high, a better feeling from alcohol than the next person. And when you get to that second drink or that third drink, your body doesn't really want to stop. So that's a warning sign. If that kindles that craving, we know now that alcohol use disorder involves craving and compulsive use and continued use in spite of adverse consequences. For example, let's just suppose I had a reaction to, I don't tolerate milk well, so I drink some milk and maybe I throw up or maybe I have stomach problems from that.
Right.
Now, a normal person with average common sense would say, I'm not going to do that again.
I understand.
But the paradox for people with alcohol use disorders is that many times they get that craving, they drink too much, they wake up the next day with a hangover, they're late to work, they miss a test at school, they get a DUI, maybe they have a wreck and end up in jail. Now the common sense thing would be to say, I don't need that, I'm not going to do that anymore. But the characteristic of the disease is that in spite of those consequences, people rationalize, well, it was really something else, and continue to go back to that behavior, and that cycle continues to repeat itself. So if you want a simple way to diagnose alcohol problems, it's that continued use despite those consequences.
In spite of.
Wow. Going back to it again.
Right. This is a call to action.
A call to action.
I'm your host, Alex Tavish. I'm interviewing Dr. Paul Seale, MD, family practitioner, amongst other things, alcohol and drug expert. And what we're doing is we're having a discussion on alcoholism and the effects of alcohol and how many drinks one should have, whether you're a man or a woman, within a 7-day period. But, let's talk a little bit about prevention and treatment. Let's just say that there's a person, who is an alcoholic. What approach can he or she take in trying to rid him or herself of the disease? Now, I know at one point they used to say that you have to have a made-up mind, but let's talk about the treatment of how to get off of it or what one should do in order to maybe do better in that regard.
Great. Sure. So it absolutely depends on the choice and the will and the decision of the person that has the problem. And so the first thing is to try to take an honest look at the consequences of the alcohol or the drugs, and then to seek help. So what might that look like? Some people do make a decision to stop, just to stop and put it down and I'd pick it up again. And we used to think that that was unusual and very difficult, and some people thought impossible. And now there's some research that indicates as many as 75% of people who develop alcohol use disorders make that decision and quit on their own.
Wow.
And so we take that seriously. And when I talk to patients now and they say, well, I want to try on my own, I used to say, well, I think science indicates that you really need some help. But the science now is pointing in a different direction and saying, well, tell me what kinds of things like that you've changed in the past. Have you stopped smoking in the past? Have you lost weight? Have you developed an exercise routine? Have you made other healthy lifestyle changes that would predict, if you really make up your mind, that maybe you can do that? So a lot of people can get better on their own. At the same time, that means if 75% get better on their own, 25% need some kind of help. Now, what does that mean? It may be professional help, or it may be peer support kinds of help. So one of the longest standing effective programs in the United States is the 12-step programs, Alcoholics Anonymous. Now, there's a faith-based program that modeled after that and includes the same 12 steps called Celebrate Recovery that's active in a lot of churches in this part of the country. So finding a friend, looking up on the internet or in the phone book and contacting Alcoholics Anonymous. Most people probably go to their first meeting with somebody they know who goes to those
So you're
meetings.
telling me that Alcoholics Anonymous works?
It does. It certainly does. So that's another avenue, and it's a very inexpensive one. It's supported by the groups. They pass the basket, and if you have something you can put in the basket, you do. If you don't have anything to put in the basket, then you're just as welcome. So that's another avenue. Yet another avenue are our formal treatment programs. So I'm a family doctor. I actually also do addiction medicine. And so at the Family Health Center, we take appointments from people who have problems with alcohol or drugs and want to try to find some help. And so we do different things depending on where the person is. We use some relatively recently developed counseling approaches. We use an approach called motivational interviewing that tries to identify what is this person's motivation, what's important to them, why might they want to quit, and then try to help them build a strategy based on what they really want to get out of life.
Yes, sir.
And that tends to be very motivating to people. Sometimes people need a detox, and so that's an important thing to know, that if you're drinking alcohol and you stop for 12 to 24 hours and you start to get the shakes, nausea, vomiting, especially if you start to see or hear things that are not there, that has some potential medical dangers, and so you should really seek medical help. You can do that through the emergency department at any of our local hospitals, or with your local physician, or with the detox center that's run by River Edge.
Yes.
And then there are formal treatment programs, and so the local hospitals actually have inpatient treatment centers. They usually focus on that first part of detoxification, get people started in their sobriety, and then move them into intensive outpatient, where they meet with individual counselors, they meet in groups. Most of those programs include some of the 12-step programs like AA or NA, and they build what's called a day program or an intensive outpatient program.
I haven't heard you mention medication.
So the one thing I hadn't gotten to yet was medications.
I was thinking maybe that was not any.
Yeah, so that's an interesting area that continues to grow. We have a medicine that most people refer to as antabuse. That was its trade name. It's actually called sulfiram. That if you take the medication and then you drink on top of it, it makes you really sick. So that's been around for a long time. There are two newer medications approved by the FDA. One's called acamprosate, one's called naltrexone, that decrease that craving. So again, if I were one of those people that had that craving and I decided I want to quit, then I can take those medications and that desire won't go away completely, but it decreases. So those medications can be helpful as well.
That's very, very interesting, and I really appreciate it. Now let me ask you a question. What would be the best approach, other than listening to Seale and Habersham, for one to for one to really become familiar with and exposed to this information, because I'm sure there are going to be people, who listen to us who have some interest in addressing it, either themselves or they got relatives or friends or significant others. So if someone is listening, what should they do to kind of get an understanding or some knowledge about the things that you discussed?
And that's a great question, because there's a lot of misinformation, and there's a lot of, I'll say, cultural myth, I think, that's grown up around this issue. There is a group called the National Council. It used to be called the National Council on Alcoholism. I believe they're now called the National Council on Alcohol and Drugs, that manages public information and education. So people are welcome to come to Navcent and go to the library on the first floor at Navcent. We have information there. If you're going to go look online, you have to be careful, because there's good information and there's not so good information. But I would look for that information from the National Council. And Alcoholics Anonymous, Narcotics Anonymous also have a lot of helpful information. So those are helpful sources to begin with if you're going down that search. It really is helpful to find someone who is a professional.
But not all family practitioners have the specialty that you have.
Right. In fact, there is just last year, a new medical subspecialty was approved and by the national governing bodies for addiction medicine. So we have that new credential, but we've only got 2 of those people in Macon. So a little bit.
Now, do you, not trying to boost your business, I know you're busy, and that's not the purpose of this program, but do doctors, who are certified, see patients? Can patients who have the problem make an appointment and come in and
Absolutely.
Seek assistance?
Absolutely.
Oh, okay. Well, let's talk a little bit about.
Let me plug River Edge here too. Probably the place that gets the most funding in Macon.
I'm familiar with River Edge.
For treating people with alcohol and drug problems is River Edge.
Yes, sir.
And I put a shout out to them, thanking them for the fact.
And it's a nonprofit organization.
It's a nonprofit organization. They're funded by our tax dollars,
right.
So that's a good thing. But they restructured their patient care so that if you've got a problem, you got an emergency, you can go any day of the week, Monday through Friday, and as long as you get there before 8 a.m., you will be seen.
Wow.
So they're not.
And they have physicians as a part of that too, don't they? And counselors and psychiatrists.
They have lots of professionals. Not so much psychiatrists are hard to come by, and
psychologists
physicians
maybe.
But a lot of addiction specialists there.
Okay.
Absolutely.
Okay. So let's talk a little bit about other kinds of drugs.
Okay.
We had this problem with cocaine and heroin, and I understand that some of the really drug dealers are now fentanyl, or what is it called? Fentanyl. They are not putting that in heroin and things of that nature. So let's talk about a little, if you would, about the use of other kinds of drugs, be it marijuana or opioids or concoction. What's that? Concoction? What am I trying to say?
Concoctions of drugs?
No. It's a real common drug. That's a pain pill. Oxycontin. That people are abusing. Talk about that and how people get on it, and what will be some of the approaches to treating it.
Right. So there's 2 main pathways that people get in trouble with those strong pain medicine, opioid pain medicines, the ones that you're talking about. And one is we have a lot of young people who are just experimenting and thrill-seeking, and maybe they raid the medicine cabinet, maybe a friend gives them a pill to try just for fun, and the opioids are at the top of the list now for that phenomenon.
Now, is Oxycontin an opioid?
Oxycontin is an opioid. It's a long-acting opioid.
Wow.
And so many people who are might in 20 or 30 years ago have simply drunk alcohol or smoked some marijuana now may start early on with taking pills to see what kind of effect they cause, and very quickly end up on opioids because that's the big player on the street right now. The other pathway is that we see people who have a pain problem, a long-standing pain problem, start out with these medications to relieve that pain, and either continue for too long or find that it has, again, that particular boost, that particular thrill for them that makes them want to continue on. And so through the pain problem, they get into taking doses that are too high for too long and buying drugs on the street and so forth. So those are the two ways that people, main pathways that people get involved with opioids.
Okay, how about heroin and cocaine?
So heroin and cocaine, you can't get from a doctor's office, so that's different from the opioids.
Okay.
And so they're exclusively bought on the street. But before we go too much longer, I want to talk to you, because you highlighted prevention, and I think this is so important. One of the things that's important to know in relationship to a prevention is that all of these substances affect a particular area of the brain. So the receptors for cocaine and marijuana and alcohol and opioids are all in the same part of the brain. And that part of the brain is very susceptible during adolescence to the early effects of those substances. So we now know that kids who experiment early, who expose early to alcohol and drugs, and especially to the point that they get a high or an intoxication, or they have an ongoing relationship with one of these substances, change their brains so that they are more likely to develop a dependence and a use disorder in late adolescence or adulthood. So some of the thoughts that people have had along the way, I want to teach my kids to drink at home so that other people don't teach them bad things.
Not good.
Not a good thing if we're talking about adolescence. We know that the longer we can postpone that first use of any of these mood-altering substances, the more we're actually protecting against the development of a disorder.
Well, believe it or not, we have spent our time, Doc, and this has been phenomenally interesting. And as it relates to the resources, they can go to the library at Navicent. But most importantly, if in fact you want to learn more information about what Dr. Seale has talked about, then you can visit River Edge and make an appointment, or Google it, or call, because the good news is that there is an approach to doing better in all of these things, and we certainly appreciate you, your information and your knowledge and your interest in making this a better community for all of us by decreasing the use of alcohol and drugs. This is a call to action.
A call to action.
Having interviewed Dr. Paul Seale, a family practitioner and medical expert. Have a great day.